Okay, if you want to give the intro, Ernie, I've got the anthem queued up.
Good morning, everybody. And we have a very special guest today. Dr. Piggot is the Commissioner of Health for Long Island's Suffolk County. And he'll be talking for a while. But first I want to thank everybody who has made this possible. That would be our sponsors. That would include Covanta, National Grid, Henry Schein, and the Louis Joe's organization. And did I miss anybody, Lynn?
Yeah, Gershow.
Gershow Recycling. They've been with us, and for some of them for a number of years, and it's been very helpful for us to make this happen on a regular basis. Today we have the pleasure of having one of our board of directors meetings, hosting the meeting. Lisa Kerr is vice president of Henry Schein, and I'm going to turn it over to her and let her introduce our speaker. Good morning, Lisa.
Before we
Good morning.
But before we have her do the introduction, we do the Star Spangled Banner, right?
Oh, absolutely, I forgot.
Okay, and then Lisa, once that's done, you'll know it's done, and we'll introduce the speaker.
Okay.
Here to honor America with the Star Spangled Banner, please welcome the Grammy Award-winning multi-platinum recording group reuniting for a performance in their native Houston, the one and only Destiny's Child.
Oh, say, can you see by the dawn's early light what so proudly we hailed at the twilight's last gleaming, whose broad stripes and bright stars through the perilous fight o'er the ramparts we watched were gallantly streaming, and the rocket's red glare, the bombs burning in air, gave proof through the night that our flag was still there. Oh, say, does that star-spangled banner yet wave o'er the land of the free? And the home of the
Houston's own Destiny's Child.
Again, another good selection.
Yeah,
And
right?
And they're from Houston,
Yeah,
which is about to be Frank's new hometown.
it is.
So I have the pleasure of bringing Lisa Kerr on. And Lisa, I think you're going to do the introduction of Dr. Piggot.
Yes. Good morning, everybody. I'm Lisa Kerr. I'm the VP of Global Risk Management and Business Continuity at Henry Schein. And I said to Ernie, I had a particular interest in hosting an event around the topic of COVID and health. So I'm very pleased that he was able to get Dr. Gregson Piggot. Thank you for coming and joining us today. He's the Commissioner of Health for Suffolk County and has been as of February 28th, 2020. He served as Director of the Office of Minority Health in the Suffolk County Department of Health Services in Long Island, New York since June 2009. And he also served as the Medical Director for Suffolk County Emergency Medical Services and as a physician in the Huntington Methadone Treatment Program, which was a critical program to provide medication-assisted treatment to county residents suffering with opioid use disorder. And so Dr. Piggot is board certified in internal medicine and is a clinical assistant professor in preventive medicine at Stony Brook University. He studied at Brown University to obtain his MD and also at Harvard School of Public Health for his master's in public health. He's worked as a primary care internist, attending physician in community health centers in several areas in Massachusetts. And he continues to be very passionate about improving the health of minorities. So thank you for being here today.
Thank you, Lisa, for having us, and thank you to your membership for thinking of me and giving me this opportunity. Yeah, so by way of background, so I'm not new to Suffolk County. I grew up in Long Island, pretty much in Nassau. I was a Nassau person for my early years. I went to Elmont High School, border of Queens and Nassau, a little town, Elmont, home of UBS Arena now. So, but then I went up to New England for schooling and kind of settled down there. And then I always had an itch to come back home. So I've been back here since 2008. I first latched on to the county health department. There was an opening in a small office called Minority Health, which was set up primarily to advocate for communities of color in Suffolk County. So I took the leadership role in that particular office, and we did a lot of programming concerning issues that were pertinent towards African-American, Latino, our native Long Islanders, primarily Shinnecock and Uncochung Indian nations, and also the Asian American community. So we did that. And when you're with the county, generally, if they like you, they give more things to you. So, so I inherited a couple other hats. I inherited public health emergency preparedness and emergency medical services. And so then I served as the medical director for the EMS system in Suffolk County. So all of our first responders were working under a medical license, at least the first responders in the EMS realm. And that's very important. It's very important. They're an underappreciated group. Whenever you call 911 with chest pain or abdominal pain, and you expect those EMTs and paramedics to show up and give you good care. So that's, they're not appreciated enough. So I always try to make sure that we give our emergency medical service providers some recognition and respect. Also, another hat because I always had a clinical itch. I'm an internal medicine physician by training. So just to keep my clinical skills sharp, the only opportunity we had in the health department was our methadone clinics. Suffolk County Health Department, we're the only provider, even currently, of methadone to those who are suffering from opioid use disorder. And that, as we have still, we're still in the middle of an opioid epidemic, if you will, that really started in around the 2010 or so area, around that time, where it was a lot of prescriptions of opioids given for chronic pain, and then people getting habituated to taking opioids and then not wanting to feel the effects of opiate withdrawal. And then as those prescription pills dried up, people switching to illicit substances. So that is still an issue that we're dealing with. We had thought we were getting ahead of it finally before the pandemic hit, and we've had a rebound in 2020 and 2021 in terms of opioid overdoses and opioid overdose deaths. So it's still an issue, and the pandemic has really worsened that. But methadone is something that is underappreciated as well, just because folks don't understand, it's not just enough to get clean and sober and that, I haven't used now in a month. To sustain recovery, sometimes you need a little help. And it's the treatment communities realize that it's not just about detox and staying sober. Sometimes you need medication to help you, especially with the effects of withdrawal and not feeling right in terms of opiate use. So that's methadone is something that's a good tool in the toolbox to have, and something I was very proud of doing for the county. We still do that. We still have our methadone clinics, and we're hoping to expand those services as we go. All righty, so I served under my predecessor, Jim Tamarkin, who's a friend and a mentor.
Doctor, I'd like you to follow up on that last piece. I want you to tell me, don't we need to do psychological work with these people who are addicted rather than just the medicine that can be administered?
Well, yes, that's a part of it. Treatment is all encompassing. There's mental health, behavioral health components to it as well. A lot of anxiety and depression. So you're going to need probably a substance abuse counselor and probably a therapist and maybe even a psychiatrist in addition to the medication. But the medication helps you to focus on your treatment. And what methadone does is that it gives you a kind of steady state of opiate in your system because you don't function normally without having some kind of a opiate in your system. And then if you're not feeling the effects of withdrawal, which is very painful, then you're able to focus on your recovery and work on your other issues that got you to where you were in the first place. So yes, that's always a comprehensive treatment plan that's important to treat people suffering with opioid use disorder. But yeah, it's twofold. It's the medication plus the behavioral health treatment.
And I have a question about the methadone. How long does a patient need to be taking it to finally recover? Or is it like a lifelong need once you're fighting that addiction?
It depends. I would say that if you are on the younger side, say under the age of 30, you can get to a steady state, get your recovery in order, get into a good routine, and then start backing down on your dose of methadone. And maybe hopefully get off. But as you get older, it becomes much more difficult to deal with the withdrawal and just the absence of opiates in your body, and it's harder to back down. So some of those folks, and I think age is probably the biggest factor there, do wind up being on methadone as a sustainability or being sustained on methadone for many years. But it is variable, and it's not one and done or not a quick treatment.
Right.
Once you're committed to that kind of a medication-assisted treatment, you're going to be on it for a while.
Understood. Thank you.
All righty. So I became commissioner February 28th. Dr. Tamarkin, my predecessor, he had served us for 10 years and was a good leader and a good mentor. And at the time, we heard something about new virus that was in China and circulating in China. SARS-CoV-2, they called it, or I think it was nCoV something. They had a novel coronavirus 2019 before they changed it to COVID. And then the thought at the time was that if we as the United States, and particularly, I kind of look at our own area, Suffolk County, that was my charge, were to monitor travels coming in from China, that we would be on top of it and we would keep this pandemic from hitting our shores. And so that was the mission. And so we were given traveler lists of people coming in to Newark and JFK airports. And we were advised to monitor these travelers and check on them twice a day to make sure they didn't have any symptoms such as cough or shortness of breath or fever. And so we did that. We felt very confident we were doing our jobs and that we would keep this virus at bay. But what we realized soon was that testing was very limited. In fact, you could not get a test for COVID in, say, February or March of 2020 without having some kind of a travel history. And then that was the sticking point, that if you didn't have a travel history, you wouldn't even consider for that. So you would have the State Department of Health at Wadsworth collect a sample and then try to submit it to the CDC for COVID testing, and it was rejected a lot of the times. And then there was one situation, I believe it was on the West Coast in California, where a person had some kind of atypical pneumonia, and it did not respond to IV antibiotics. It did not respond to treatment for viral pneumonia. And they petitioned, and the CDC finally relented and said, okay, we're going to test this person for COVID. And lo and behold, that was positive. And so that became, started a cascade. So now all of a sudden, now the CDC was allowing testing in limited circumstances in people who were hospitalized, even without a travel history, but had some kind of weird pneumonia that did not follow a typical pneumonia pattern. And so we found it. And so March 8th of 2020, I get a call from the State Department of Health. Congratulations, Suffolk County, you have your first COVID case. I'm like, okay, well, let's see. Nassau had their first one on March 5th, and that was a Thursday. And then this was a Sunday, I'm getting a call. So I'm figuring if Nassau had it first, then it's probably circulating from folks that are commuting to the city and coming out here. So it's coming from west to east. So I'm thinking that Suffolk's first case was going to be probably, you know, someone who lives maybe in Melville or Huntington or Dix Hills or something like that. You know, who might have been hospitalized in Huntington Hospital, something like that. So I'm like, okay, so it's someone in Western Suffolk, right? He's like, no, this person lives in Greenport. I'm like, Greenport, okay, I wasn't expecting that. So deep in the North Fork. And let me guess, he just got back from China or something, right? It's like, no, he's a local. He doesn't leave the area. I'm like, huh? So that totally blew my mind, because we're deep in the North Fork, so we're not even close to the city. And, you know, this is a young gentleman with no travel history. I think he worked at a restaurant, and he was hospitalized at Southampton Hospital. It was our first COVID case. And so, you know, kind of scratching my head, I'm like, so it's already saying that this is a local person that doesn't travel and it's in the East End. You know, it's probably all over the place. And so there it was. We were deluged with COVID. It just started right there. And in March of 2020, it was a bad month. It was a bad month. So people were testing positive right and left. The main impacts that were very concerning was the effect on our healthcare system. I think that was something that we were all blindsided about. And so the hospitals were overwhelmed, swelled to overflowing. There were issues in terms of personal protective equipment, particularly N95 masks. And then as people got seriously ill with COVID, it was also ventilatory support, lack of ventilators, and talking about, well, you know, we have one ventilator and two patients. Is there any way to share a ventilator for these two patients? And so it was dire. In terms of numbers, our 911 receiving hospitals in Suffolk County, there are 11 of them. The highest census of COVID patients was 1,658. And that was April 10th of 2020. I just have that number etched in my memory. And so there are a lot of things that had to go with that. If you're dealing exclusively with COVID in your hospitals, then there's a whole bunch of other things you can't deal with in terms of things like colonoscopies or lung scans for other diseases that are not respiratory, looking for cancers, et cetera, and so forth. Elective procedures had to stop. So it was a total disruption of our healthcare system, and we had overwhelmed healthcare workers. And then the other piece of that was that people were dying due to this virus. And our first fatality was March 16th of 2020. That one was at St. Catherine's Hospital in Smithtown. That was the first fatality, someone in their 80s who had passed from COVID. And that became one of many. We lost a lot of people that year in 2020. To date, in terms of facility deaths, people who've died in either hospitals or nursing homes or adult care facilities, that number is around a little under 4,100 people that we've lost since March of 2020. All right, and so that's the scenario, or that's the situation we never wanted to see happen again, that the hospitals being overwhelmed, and then our morgues, and then our mortuaries, and how we deal with people who are deceased being overwhelmed. We were talking about the medical examiner having to rent refrigerated trucks because there were so many deceased, so many people had passed away. The funeral homes, they couldn't handle the volume.
Doctor, I wanted to relate this situation to where we are at present. For example, we seem to be going, having less and less cases. And we have, I would look at the panel that I'm looking at right now and say, almost everybody here is triple vaxxed already. Do we need to walk around in fear of being contaminated when so much has already been done? Or are we getting it to a point where we, in this, at least in this region, can feel a little bit more normal?
Yep. Yeah, I'm getting there. I just like to paint the big picture from where we came from to where we are now, but I will get to that in a second. Right, so the hospital swelled to overflowing, morgues, mortuaries, funeral homes, having situations. And our role as a local health department was to call people who tested positive and try to contain the spread of the virus until we had something that we could offer people, because there was no treatment at the time, nothing specific to COVID that actually worked. All right, we're still trying to figure that out. And so the thought in the public health and the scientific community is that we needed a vaccine. When you have something that's a viral situation, polio comes to mind in the 1950s, when you have some kind of a viral illness that causes severe morbidity, mortality, that you need a vaccine to help prime people's immune system to give them some protection against the effect of that virus. And so what we did as a local health department was essentially temporizing measures. So contact tracing, calling people and telling them they tested positive, please isolate for 14 days at the time, and if you're exposed, please quarantine for 14 days, stay out of circulation so that you cannot spread the virus to others. And that was a main message of the local health department. All right, so we got through that surge. As you know, it was a very painful time in terms of some businesses being declared essential and some non-essential. Schools essentially being shut down in March of 20. And we had to learn how to do everything remotely. And even today, we're doing this meeting via remotely via Zoom, whereas, you know, everything had been in person prior to that. And so we got through the summer of 20. We did not have another surge. Some other areas of the country had a second surge in the summer of 20. We got to the fall, and then we did have blips that occurred around social gatherings. So Halloween of 20, Thanksgiving of 2020, and then Christmas of 20, and then New Year's 2021, we saw a surge related to that. The hospitals did get busy again in the winter of 20 into 21. The high point there being 863 patients around January 19th of 2021. And then an increase in fatalities, but not as bad as the dark days of the pandemic in March and April of 2020. The vaccines came into play in December of 20. We got the Pfizer vaccine approved. And then subsequent to that, the Moderna vaccine approved. That was a new technology that had been in development for years. It was messenger RNA, which essentially is the instruction material to tell your cells how to build something. And so the messenger RNA sequence in this case was telling you how to build these spikes, which are on the outside of the coronavirus, because the key to neutralizing that coronavirus and preventing it from multiplying and damaging cells is to attack its spikes. And so that was a technology that was deployed and very effective in the clinical trials. All right, so that was rolled out, and we started to see a significant reduction in our hospitalization, particularly seniors. Whereas if I looked at the hospital census in January of 2021, and I saw that 863 numbers, that was predominantly people over the age of 65. In fact, it was 2/3 of that hospital census with people over the age of 65. And as we started rolling that vaccination campaign out in the winter and early spring of 2021, we started to see something very interesting, that the proportion of people who were hospitalized with COVID started to drop, and then now it became more people in their 40s and 50s. And at the time when I looked in April, so in 3 months' time, it went from 2/3 over the age of 65 to about 40 to 45% over the age of 65. And that was the result of the vaccine. So it showed me right there that the vaccine is having an effect and that it is working. All right now, so what happened there? So in June of 2021, we felt we had control of the situation. The numbers were excellent. We had reached a certain point where I believe 70% of adults 18 and older had received at least one shot of one of these vaccines. and we were doing well. Then the virus seems to always outsmart us in some way. So then essentially we had COVID 2.0. So there was a new variant because the virus mutates all the time, and it just happened to hit a mutation that seemed to be very effective and easily spread and causing more disease. So that was the B.1.617.2 variant, or the Delta variant, which was birthed in India. And at the time we heard it was coming, we were like, yeah, these vaccines are great. They're, they're what they said they were. They're going to stop everything. And lo and behold, because of the mutations on the spike protein in the Delta, and there were about 10 different mutations on there that were different from the original strain, we were having what we call breakthrough infections. So people who are fully vaccinated, who got 2 doses of Pfizer or 2 doses of Moderna or 1 dose of J&J, were all of a sudden testing positive in higher numbers than we had seen before. And it's like, okay, well, yeah. So yeah, people are getting some breakthrough infection, but they're having milder symptoms, and the vaccines do offer some protection. Even if you do get infected with COVID, it's really not causing significant damage. People are getting over those infections quickly. So we did have a Delta wave that peaked in August of this past year, 2021. Hospitals again started to see a little bit more action. The case counts went up. We got to around 260 in terms of hospital census. That was September the 10th of 2021. All right, so Delta remained the predominant strain, and I was worried coming into the fall and winter of 2021, just because if the same pattern repeated itself, then we were going to have surges again around Halloween, Thanksgiving, and Christmas. And so I'm like, okay, we're going to have a winter surge. I don't know what it's going to look like, but it's pretty much, based on that pattern, based on people getting together in indoor environments because it's cold and we don't congregate outside anymore, we're going to have issues with a surge. Little did I know that we were going to be besieged with another variant. And so that broke around the 3rd week of November, that there was a new variant out of South Africa, and that one was called the B.1.1.529, and later named the Omicron variant. And they said that this one was so contagious that it was going to wipe the Delta variant, which was the only variant we had at the time. It was going to wipe it off the map and just take over and become the predominant variant. And so I'm like, yeah, right. Delta is pretty contagious as it is. It's causing diseases. That's not going to happen. And so, I think they had tried to prevent it from coming in. And we had our first identified case around the last week of November. It was a traveler from South Africa who was living out in the Hamptons. I'm like, okay, that makes sense because it was birthed in South Africa, and then this person traveled from South Africa. But then the cases subsequent to that were people who had no travel history. I remember there was some kind of an anime convention in the Javits Center. And then in the city, they're very strict. They checked people's vaccination status at indoor venues at the city. Usually they ask for a driver's license and some kind of a proof of vaccination, even before they let you in a lot of these places. And so you didn't think it was going to spread in an environment where they check people's vaccination status, and yet lo and behold, it did. And so that was the kind of warning flag about Omicron, is that it can spread even amongst vaccinated people. All right.
I'd like to ask a question. I'm sorry to interrupt. This question of the breakthrough cases, and you had mentioned before how the vaccinations are to create antibodies to recognize and fight the spikes, right?
Right.
How is the immunity from actually having COVID the same type of antibody response? And there's a lot of, I guess, discussion in the community now around, well, even if I have my 2 vaccinations and my booster, I can still get Omicron. Wouldn't it be better to just get the illness, get the natural immunity, and would that not be stronger than the vaccination that was for a previous strain? Can you speak to that?
Yeah, it's unfortunately it's a weaker immunity. If you just have natural immunity without the vaccine, generally you're making antibodies to all sorts of other pieces of the virus, not just the spikes, what they call the nucleocapsid, which is kind of the actual virus molecule, the little ball in the middle, not just the spikes. And it's a weaker immunity, and it wears off, unfortunately. And, 90 days is what studies are showing, that after 90 days, after a natural infection of COVID, that you're set up for whatever comes next, whether it's a slight alteration of the virus that's circulating or a brand new strain, but you're susceptible to that. Actually, the best form of long-lasting immunity is the vaccination plus a COVID infection. So if you had a COVID infection, then you got vaccinated subsequent to that, that seems to be kind of the gold standard in terms of not getting reinfected with COVID.
And if you do get the infection, how long should you wait to get, if you were in the middle of about to get your booster, let's say, you have your 2 shots, then you get the strain. How long should you wait after you're sick to get the booster?
As soon as you're better. Pretty
Really?
much, Omicron, thing with Omicron is that it's quick moving. So it attacks quickly, multiplies quickly, and gets out of your body quickly. So that's why they reduced the isolation time from 10 days to 5 days, just because Omicron's whole cycle is much quicker than Delta's. That's where that came from. So now we talk about isolation, and if you're exposed, quarantine, that being 5 days in each case now, cut in half, essentially because of how Omicron moves. It's a different form of the virus in that it's more upper respiratory. The problem with the previous strains is that it really damaged the lung tissues and made the lungs really essentially useless. And even with ventilatory support, people had a lot of trouble breathing. But Omicron is more like upper respiratory, more like a flu or like a cold in terms of sore throat, stuffy nose, congestion, mild cough. And then by and large, people who are vaccinated, and particularly vaccinated plus boosting, you have a milder case, and you have essentially a cold for a few days, and then it gets out of your system. So that's the advantage there. But if you don't have any kind of protection at all from vaccine, then you're at risk for having that severe pneumonia. Unfortunately, we've had fatalities again. This month of January, we've had double-digit fatalities pretty much every day of January, save January 2nd. But it's been, bad COVID deaths. We had 24 on January 19th in our hospital. So
Are they
it's very
generally
serious.
unvaccinated people that's happening, Doctor?
It's predominantly unvaccinated. Remember, Suffolk County, we are a very well-vaccinated region. Long Island as a whole, we are around 77 or so, between 75 and 80% fully vaccinated as a region, which is excellent coverage. But disproportionately in the hospitals, you'll find it's about 60% of the unvaccinated taking up hospital beds with COVID infections. So even with the vaccination coverage we have, we still have traffic in our hospitals that's more unvaccinated than vaccinated.
And what is the age range of those hospitalized with this variant?
It's pretty much middle adults. I'd say between mid 40s to mid 60s. So 40s, 50s, and 60s. That's the bulk of the folks that are hospitalized.
And there is a question here I see in the chat about this question of the vaccine recognizes the spikes. Is that the most effective way? Or the question actually relates to, will there ever be a vaccine that causes the body to recognize the entire virus body, not just the spike?
Yeah, they've tried different things. There was the one in China, I think it's called Sinovac, which is an inactivated coronavirus vaccine. So that is a hollowed out coronavirus. So that's the entire molecule. And they found the antibody response to that was not as robust as to the messenger RNA products. We have the top two in terms of effectiveness. The Pfizer-Moderna vaccine are the most effective of the ones that have been out there. There is also the virus vector vaccine, which is similar in technology in that it's an inactivated virus, so a hollowed out adenovirus, which is like a cold virus, with DNA molecules that actually encode the spike protein. So that's the same thing. So that is your Oxford, AstraZeneca, and Johnson & Johnson vaccines. Those also produce an antibody response, but not as strong as the messenger RNA vaccines. So there are other options out there. It's just that in the US, we just have those three, the two messenger RNA and the one virus vector vaccine. There was another one, Novavax, which is just spike proteins like put together. And then that, I think they gave up because Pfizer and Moderna pretty much cornered the market in the US, so that there was just not enough, I believe it's a capital issue in terms of developing that one further. But I think overseas, Novavax did get some approvals and it seems to actually have some effect.
Can I ask a question about the Novavax?
Yep.
If I have a friend that was in the trial before everything got approved, and she got both shots, and then came out of the trial to know that she definitely did get both shots. Now it's not approved in the US, so does she need to then go get a Pfizer, Moderna, or to just get a boost? Like, how does that work?
Yeah, recommendation there is just to get a booster of one of those other two, the Pfizer or the Moderna.
But it's not approved in the US, so.
Right, but I believe it's the World Health Organization considers that a vaccine that's effective. So what the CDC will do is saying that because you got a WHO approved vaccine, then all you do is get a booster. You don't start a primary series of a new vaccine. So it's considered that you're primarily vaccinated against COVID with a different product, and then now you're eligible for a booster of a US approved product. So you get a booster of Pfizer or Moderna.
Doctor, I have an interesting question on the ordinary flu. We have hundreds of thousands of cases of ordinary flu. We usually get about 60,000 people who die from the ordinary flu. We're so effective on doing this more complicated, what I think is more complicated COVID. Why can't we use some of that technology to marry it to the ordinary flu vaccine that we get, which is not all that effective?
So you pose an interesting point. So we
Well,
follow
I'm not
the
a
flu.
scientist, so I don't know what's impossible.
So we follow the flu every year. So that's, they always put up nice graphs. The State Department of Health monitors all the flu transmission throughout the state. So very interesting. 2020 into 2021, we had no flu season whatsoever. It was a flat line. And that was a result of measures such as masking indoors and social distancing, gathering restrictions. We had no flu season whatsoever. This year, without any of that in place, we started to have a flu season, and it actually peaked around mid-December, which is very interesting. It had a trajectory. It was going up like this. Then all of a sudden, when the Omicron wave hit, it started going down. So we're in a downward trajectory now with the flu, which is very interesting because I think people started being more cautious, right? That's what I'm seeing. When I'm going out and I'm going to the Targets and Costco's, et cetera, I'm seeing much more masking in an indoor environment. And that cuts transmission of whatever the respiratory virus is. In terms of what you're saying about flu shots and the effectiveness, every year you're recommended to get a flu shot. So they tweak the formula of the flu vaccine based on what is expected to be circulating in the coming flu season, using what they call the H3N2 strain of the flu. I think what's going to happen with this SARS-CoV-2 virus is very similarly, as you have more and different mutations of the virus, you're going to have to start tweaking the formula of this vaccine. And so I'm expecting probably somewhere down the road, there's going to be a booster for the predominant SARS-CoV-2 strain that's circulating, and we should probably get that. That's what I'm thinking is probably going to happen in the future, just because the virus continually mutates. And we're at now, COVID 3.0, going from the Alpha to the Delta, now to the Omicron. So it's looking in the future that we're going to need to change the product because, as you know, we're vaccinating and boosting with a product that was developed with the original strain in mind, but the virus is now going through two different waves and mutations. And so that the virus is not as effective because it's a different strain that's circulating. So.
I want to tell people that are in the audience that if they want a question that answered, they will put it in the chat box, and Lisa will either give you an open mic or she will ask the question for you. That'll be your choice. So I just wanted to interrupt with that. Go ahead.
I did have a question on that point. So suppose you're someone who has the 2 vaccinations, you haven't gotten the booster yet. Should you bother getting the booster, or should you wait for the next vaccination that will, take in the latest strain and maybe be more effective for what's coming?
Yeah, problem is you have a strain circulating right now. Omicron is still here. We peaked around January 5th in terms of transmission in Suffolk County, but it's still pretty high. We're still getting 1,500 to 2,000 people testing positive with this variant. And then that's now just a sampling of how many infections we have per day. A lot of people are testing at home or not testing at all. So there's probably much more Omicron circulating now. And we're seeing it is having an effect on our emergency rooms. It is having an effect on our hospitals. And so unfortunately, if you're waiting until the next formula or next booster to come out, that might be, who knows, maybe summertime. And so you're probably going to be exposed to Omicron before that. So the recommendation is to get that booster ASAP, just so you have that protection, because we're finding that people who are vaccinated plus boosted get very mild symptoms, if any symptoms at all, with Omicron.
And are those symptoms more mild than if you just had the 2 vaccinations, I suppose?
Yeah, the booster.
Like you could still, okay.
You
So
can still test
get it,
positive, you're
yeah.
still infected, but you're not going to wind up in the hospital or on a ventilator.
Okay, interesting. And what about all the talk about these different masks in the media? I mean, I think the most frustrating thing for me throughout this whole pandemic is conflicting information, right? Different doctors tell you different quarantine periods. Now there's conflict over whether the masks are effective at all if it's cloth, or you need the surgical masks,
You have to look at the long game. This is a soap opera, right? So, as the world turns, there's different plot twists. Right? If we were looking at June of 21, for example, we would have said, okay, the original B1 strain and the alpha strain, we beat that. Pandemic is over. But then the virus has another twist in the plot. So now it comes with a new mutation. And so the science changes and you have to adjust your messaging. So before that is that the vaccines are 100% effective in preventing hospitalization and death. So we had to tweak that message when Delta came along, because now you were having breakthrough infections, and some unfortunately resulted in hospitalizations and death. So you had to tweak that and say, well, the vaccines are effective, but they're not 100% effective, but you're more likely than not going to get protection that's going to keep you out of the hospital and keeping you out of the ICU. And so the messaging changed as the variant changed. And so now with Omicron, because it's an upper respiratory virus in particular, now the quarantine and isolation periods have come down, cut in half. And then the messaging is similar in that the vaccines do give you protection from the worst outcomes, but it's not enough to have 2 shots. We're finding that with Omicron, you need a 3rd shot as well. So it's not really confusion. It's just that as the virus evolves and as we have different waves, you have to change your messaging based on what's the science that's available or what's out there.
So I see Triumph has a question. Would you like to ask it yourself, or do you want me to read it for you? Oh, he's on mute.
Yes, I can ask the question. Yeah, doctor, thank you for the resourceful discussion today. Just out of curiosity, do we have any new information about the origin of COVID-19? And we know that a team, I guess, from the World Health Organization, a US team and a European team went to Wuhan, China, and the Institute of Infectious Diseases there to investigate, but we didn't hear any more ever since. So do we have an update on that?
Yeah, that's not something I generally follow as a public health professional. I'm looking at the situation here and how we're trying to save lives with the situation we're presented with. In terms of the origins, from what I understand, is that it was a coronavirus that was in another mammal, probably a bat, and then got transferred to humans and found to be very virulent in humans. So I don't know anything other than that. I can't really comment on theories about it being lab produced or anything like that. But
well, I guess the origin probably will give some more perspective how to fight it better. That's what I'm getting at. If we know where it's coming from, probably we can prevent it in the future. Take more effective measures.
The prevailing theory is that
spread.
It came from a bat. That's the prevailing theory. That bats do harbor coronaviruses. So yeah, but other than that, I don't have any other information for you.
Okay. Thank you.
Okay. We have another question from Alan. He said I could just read it. What criteria is used to recommend closing schools? What about nursery schools?
About closing schools, we don't tell the schools when to close or not to close. Generally, if you have, if your school is unable to function because there are a lot of people out sick, that's when the school will say, okay, we're on remote because we have the teacher, the second grade teachers out, and a lot of my staff is out, so we cannot do anything in person. So we're going to do things remote. But each school makes its own decision, and it's usually based on the number of cases and how it is affecting the ability to provide in-person instruction.
Okay. And Lawrence, do you want to make a comment?
Yes, I think you're doing a great job, Doctor, and keep up the good
Oh,
work.
thank you.
I hope to make you famous or at least get some kind of an award. My father told me, I'm from Franklin Square, he said, you were on a swimming team for 4 years. You never got a cold. We all had colds around here. I think it's chlorine in the water. Now, I think he was onto something. And I think he doesn't care what kind of a virus it is, it kills them all. Please.
Chlorine does kill everything.
But don't close the pools again. That's all.
So I think we should all swim as much as we can, right? I think that would.
Absolutely.
Yeah.
It works. It's been around for 100 years.
Yeah.
Thank
Yeah.
you, sir.
Lisa, Pete Allen has a question. I don't think we got to
Oh.
him.
I missed that. Okay.
Peter, do you want to do that yourself? You want to ask the question? Oh, I thought you.
I think Lisa covered
was
that
answered.
earlier.
Oh, yes, that was about the vaccination covering the whole body. Okay, of the virus. Got it. Got it. Okay.
I think I had one. You asked, Lisa, you asked about masks before. So
Oh, right.
yeah, the mask you're going to wear and wear comfortably is better than no mask at all, right? But we're finding that people who are wearing the cloth mask, which became extremely popular, those are a sieve. It doesn't keep anything out. So Omicron goes right through that. It says, thank you very much. You enable me to spread more. So they're finding that a higher quality mask is more effective with Omicron. So higher quality means more of a tight fitting mask. But there's a trade-off. The more tight fitting the mask is, the more uncomfortable you're going to be. And so, I think CDC even backed off the messaging and said a well-fitting mask. They're
Bogs
not.
your glasses. It bogs
Yeah,
your glasses.
Exactly. Right. Yeah. So I think the N95 type or the KN95. The major difference is that the N95 has the rubber band straps that go around the neck, whereas the KN95, which I believe are Chinese origin, they hook around the ears. But they're very form-fitting and give a good seal around the mouth and nose, and that pretty much keeps anything out. I believe it's 95% of any virus particles. So.
It's true,
Dr.
though. If it's
Piggot.
uncomfortable and you don't wear it, how good is it going to be, right? So you're
Correct.
stuck between
That's
a cloth
why.
or a surgical.
Yeah, so I'd say a heavy cloth mask. The cloth mask should have about 3 layers in it. It can't be some little simple, bandana or what was the other thing? A gaiter. Yeah, that was the other thing that was very
Okay.
popular. Yeah, those are a
Dr.
sieve. Yep.
Dr. Piggot, would you suggest those plastic helmets like that cover only the face and come like straight?
Yeah, that's
So-
eye protection. It doesn't really help with anything you're breathing in. There's no what they call source control there. Anything you're breathing in and out can go around the sides of the.
Okay,
the
because I
face.
see people wearing those around, so,
Yeah, it doesn't do anything.
okay.
If anybody's interested, I just put a link to a CNBC article about, with a link in it to find where you can get the free N95s that are going to be distributed via the government.
Are those out yet? Yeah. Oh, okay.
They're going to be out in the next few weeks.
Okay.
But they're starting to list pharmacies. In fact, I work with a pharmacy in Manhasset that is going to be one of the distribution sites. So the details are not out yet, But you can basically, once this gets going, look up where the nearest place, from your geographic location to get them. So,
Just want to, last weekend I flew and my wife, being in the medical field, had an N95 that I used. And I did not find it uncomfortable. All week, I wore it for the entire weekend and was able to
Frank
fly
froze.
and be
Yeah,
in
used to it.
environments and everything. Yeah, they're not terrible at all.
All right.
Okay.
Yeah,
So
once
Cindy
you
has
get
a-
used to it, it takes a while to adjust to it, but once you're used to it, then it's fine. And if you can get comfortable with it, it's better to wear that.
Healthcare workers, that's their standard and they've been dealing with this for years now. So,
Right, and they do fit testing with the N95s to
Right.
make sure there's no leakage.
right.
You know, most of us are not going to do that, but yeah, definitely that's a requirement in healthcare.
I see that Cindy has another question. Would you like to ask it?
Ron has a question. Let me
Sure.
just
Sorry, I had to
unmute you,
unmute
Ron.
myself. Now, I was on a Zoom board meeting earlier this week, and it ended up that a gentleman on it was getting ready for a test. He had to go for a swipe and a PCR, and it ends up that he had no symptoms at all, but they said, oh, by the way, you can't go for the procedure because you have COVID. So how many people, in your opinion, have COVID, are fully vaccinated, triple, vaccinated, and are walking around very carefully, but, yeah, I actually do have COVID, have no idea, and, it's also not reported.
You're correct.
There's also so many home tests now that people are taking and then just being really careful and self-isolating. And then, that's why the numbers are going down, but so much is not reported.
You're correct. What we see now with the daily case count is kind of a sample size, but it's not a complete number, and it's going to become less and less relevant as more people test at home, because those are not going to be reported to the state health department and not going to be disseminated to us. So you're really just looking at the snapshot. What I looked at with the case counts is the percent of the tests that are positive, because that gives me a real representation of if the virus is circulating maddeningly, if it's all over the place, or if it's just a little bit of virus out there. So for example, the highest percent positivity we had was January the 3rd, 28.1% of those tests that day were positive. That says there's a lot of virus circulating. Generally, our percent positivity has been 5% or less. And so even now, even as we're January 19th, we're around 13.9%. So the percent positivity is coming down, but we're still not out of the woods. I keep reminding people that even though Omicron has peaked, there's still a lot of virus circulating. We still need to be very careful.
You have a follow-up to that, Cindy?
Okay, so another scenario is I also had a different friend who ended up coming in touch with a client, had COVID, they were outside, didn't think much of it, ended up then did a home test. She had COVID, stayed isolated, and then, I don't know, like a week later, did another COVID test, but she was still positive. And then several days later, she tested for a third time and finally was not positive. Does that mean she had Delta because it was such a long stretch?
No, it takes a long time for the test to become negative. The main thing is, how did she feel? So if she had congestion and a sore throat, and it finally broke, and then 3 days later it's like, oh, okay, my throat feels much better, my congestion's gone, then I'd say she has. Well, at that point, it doesn't matter. You're wearing a mask around others. You know that you could be potentially infectious, but probably not infectious, just because the viral load peaks around day 3 with Omicron, then it comes down rapidly. So after day 5, if you're feeling much better, then you're probably not transmitting much virus. But I would still be careful around others and definitely be masking up when I'm around other people.
Wow, so they don't really look at if you're still testing positive anymore. Because at one time I remember, there were people who were past their 14 days and they were still testing positive, and
Right.
schools didn't want the student coming back. Has that changed now? Now it's really down to the 5 days because this is
More
a faster
5
moving
days
virus.
and your symptomatology. So if you're still feeling lousy at day 5, then you're probably still infectious and you probably shouldn't be circulating. But you
Okay.
can come off isolation after day 5.
Yeah, I know that was confusing when the quarantine went down to 5 days because at first it seemed like it was only for healthcare workers because there was a shortage of healthcare workers, and then everyone started to adopt it. So I think that it had how it seemed odd when there was such a spike. Sitting in the community, I'm thinking, oh my goodness, there's such a spike right now, and they're shortening it down to 5 days. How do you reconcile that? So, I mean, where do you recommend to get your best source of information? Because it depends what news station you watch, what paper you read. I ask a friend who's a doctor. I ask my own doctor. I get different answers. How do we get valid information in this constantly changing time?
I find the Centers for Disease Control to be the most reputable, just because there's a lot of input, and they follow the science, and then they'll do some mea culpas too. If they say something, they have to take it back. They're willing to walk it back, based on pushback from other people in the medical and scientific community. So I generally do look to see what the CDC says.
Right, and then you have to think about your own local region, right? So Suffolk County Department of Health, can we call
Right,
you
and
for information?
Yeah, and we generally get our marching orders from the State Department of Health. We're in constant communication with them. They'll put out guidelines, and then sometimes we county health commissioners, we do give feedback and pushback to the state, and they do make adjustments on things. There was one, for example, with quarantine for teachers, because you had K through 12 teachers who were fully vaccinated with 2 Pfizers or 2 Modernas, but then all of a sudden in the new guidance, if they were exposed to someone who tested positive, now with the new guidance, you have to quarantine, whereas previously they did not. We're saying this is going to be an extra burden on our teachers. It's really not fair that you all of a sudden change the rules to require now the teachers to get a booster shot. A lot of teachers have not had booster shots. And so the state walked that back and said, okay, in this particular circumstance with teachers in K through 12 schools, if you've had 2 Pfizers and 2 Modernas and 1 J&J, and you're exposed, you do not have to quarantine. You can continue to teach, but you should be masking and probably testing it day 5 just to make sure you didn't get it.
We had one more question from Ron Gulmy, who's been patiently waiting to ask it. So I wanted to get that in.
Thank you. Good morning, and thank you, Doctor. I actually had a couple of questions. So back to the masks. So it's my understanding that the N95, which was created by 3M several years ago, the 95 stands for 95% filtration.
Right.
Correct?
That's correct.
Okay. And it's also my understanding that the medical surgical 3-ply masks provide 98% filtration. Why is there such a push on an N95 when
you're talking about these kind of standard?
Yep.
Like these?
Yep.
These I think are around 60%. From what I've read.
No, that's not what they're certified to. Nope.
But problem is, if I put this on here, I've got holes here, right? It's not tight fitting around this part of my face, and then also there's another area here that's not as tight fitting. Whereas the KN95, I put this on, so it's more of a circular shape, right? And so that's covering the escape area here and also up here around the nose. So this is just a tighter fitting mask. There's just less opportunity for air to go around it. So that's why it's a better seal.
Okay. All right.
And also that cone shape allows you to breathe much freely. It's not right to your nose. That's another thing I like about
the medical surgical supply mask, I use them at the gym. And
I love those. That's my favorite mask. This is very.
You can breathe through the side, the top. It's a lot more comfortable than.
It's much more comfortable, but
in my opinion, everyone has their opinions. All right, back to the vaccines.
All right.
So I get a flu shot every September, October annually, and like you said, they're annual because of the different strains or whatever in the flus, but. So a question is, all right, so I had the 2 Pfizers, I had a booster in November 29th. What's up next? When can I expect the next vaccine? Is it going to be annually? Is there going to be a vaccine for every different, strain? I hear that we're going to be getting them every 3 months, every 6 months. What's up with these vaccines?
You're trying to predict the end of the soap opera. The soap opera never ends. You know that. As the
Yeah.
world turns, have been on for like 20 something years now or something. So I don't know the answer to that question. I think next fall, there's probably going to be a recommendation that we're going to have to get some other tweaked formula of a vaccine. That's my opinion.
And when that happens, doctor, do you think it's going to be as crazy competitive as scheduling the way it was the first time around? Because it was quite difficult scheduling unless you were in a certain age group, you had certain comorbidities, yada, yada, yada.
That was because you had very little product and you had a lot of people looking for it. That was you talking about a year ago when they first rolled out vaccine. It just wasn't enough vaccine available, and there's
Right.
a lot of pent up demand to get vaccine.
Right.
Hopefully, we're awash in vaccine when the boosters are available, and it's just much more orderly. You had the same kind of situation this past December with people looking for booster shots, and our booster clinics were overwhelmed in the county. It was just a lot of people were, because of Omicron, because it just appeared on the scene, a lot of people were looking for booster shots in December, and plus right around the holidays, because people wanted to get together with their families and friends.
We're getting ready to wrap, but I'd be happy to
Yeah.
entertain a couple of more questions. But before I do that, I want to thank two of our board of directors, Leah Arnold and Robert Doyle, for being on the call, as well as Lisa in running the meeting today. Do we have any more questions, Lisa?
Yeah,
I have
Dr.
a
Pigott,
question. Oh, go
quick,
ahead.
hold on, Lisa, one sec. Dr. Pigott, regarding the masks, for example, when you wear a mask in the morning, what's the life cycle of that mask? Once you enter a store, you should take it out and put another one, or you can wear that throughout the day and then discard it at the end of the day. So what's the lifetime of that mask that
You can wear you can wear that mask as long as you want, as long as it's not wet, as long as it's not compromised in some way with some kind of a hole in it, or if it's not dirty. I think once the mask gets dirty, then you probably throw it out and use a new one. But it's not necessarily one and done. Like I went to Target and then I got home and I threw out my mask. You can probably keep that mask in circulation for days, I would think, until it actually gets dirty.
Okay.
Any more questions, Lisa, do you see?
I have just one quick question for the doctor on vaccines for young males. So say tweens, teens. I've heard that there's a 2% occurrence of myocardia when a vaccine is given to a young male. It's something they're not seeing in females. And so the question is, with this virus not really impacting healthy children, is it perhaps safer to wait and see if the virus, if the child does get the virus? Because I heard that, if they get it, there's a chance of myocardia, but if they get the vaccination as well, it's 2% chance. And the infections are so low in children, is it in a way more risky than to give the vaccine to a young male?
Yeah, the incidence of myocarditis it's even way lower than that. I think it's like
Very
1 in
rare.
10,000.
Yeah.
It's extremely rare, and
Okay.
it's something that resolves very quickly with some ibuprofen and naproxen and time. That inflammation, that mild inflammation around the chest goes away. It's not something that causes some kind of long-term.
Oh, it's not a
sequelae.
long-lasting effect? Oh, okay.
No. And the other
Also-
thing is that you are protecting other people. If that teenager gets COVID, that teenager can spread COVID to mom and dad, can also spread it to grandmom and granddad as well. So you're stopping the cycle of transmission that could occur. And it's a lot of the spread that we've seen with COVID is within the household. So you're stopping that transmission right there.
I'll also just say that the American Academy of Pediatrics does recommend the vaccines for everybody 5 and up, including teenage males.
All right.
Thank you. I think Cindy has one last question and we are done. We have used up all this time with the
Thank you.
doctor here.
I just have one follow-up about when you were talking about the Novavax. I know that when my girlfriend chatted with her doctor and CVS or Walgreens or wherever, no one had any answer but you were right on it. And they were like, she ended up started on a series with Pfizer. So she has 2 Novavax. She has 1 now Pfizer. So should she not get anything else? Or is the first Pfizer dose the same as the booster, or?
I think she's in good shape with just the 1 Pfizer shot. I mean, there's really no harm for her to get a second Pfizer shot. It's kind of up to you, up to her at this point. But I think she's in good shape right there.
Okay, so just one more. Okay, so she got 2 Novavax, then she ended up getting COVID. And then right after she was better, she ended up getting the first Pfizer series of, so should she just stop? And she's now overly immune?
I would think she's pretty immune.
This is the gold
Um,
standard.
Well, thank you for sharing everything, because I didn't have a clue of, yeah, she got 2 and then she got right ahead. One more follow-up question. I heard that there's COVID anxiety.
We have COVID fatigue, we have COVID depression, we have COVID anxiety. Absolutely, it's all out there.
So then how do you, what?
You gotta wrap it up, Cindy.
Oh, all right, okay, so what tools are there out there, or was there research to help support my friends on this COVID anxiety and depression?
And mental health is the other pandemic. I was talking about the rate of opioid overdose deaths has gone up in 2020 and 2021. There's a lot of anxiety and depression, and people need to seek mental health services definitely around this time. That's going to be the next wave we're all going to have to deal with is our mental health.
Thank you.
Before I thank everybody.
Thank you
and
very
say-
much.
And say good morning to everybody. We're going to have an interesting program. We have legislator Theo from the East End is going to be proposing municipal power on our next meeting. I think that's going to be a very controversial topic, and I think it's going to be a very interesting topic. So please join us then. Is there any closing remarks, Lisa?
I would just like to thank Dr. Pigott very much for being so open with us and answering
Thank
a
you so
number of
much.
questions. In this, there's a lot of questions. It's a very interesting topic, and we appreciate your time.
So I've been dealing with it for 2 years is COVID. I'm tired of COVID. We've past this COVID stuff already.
Us too.
New soap opera.
Everybody else is right there with you.
And where we are.
Thanks,
Okay.
you did a
thank
great
you so
job
much.
today.
Thank you, Lisa, for taking charge. And also,
You're welcome.
all of the people that came and all of the interesting questions. I'm so happy that there was such a good dialogue between us and the doctor, and I'm sure he appreciated, using his knowledge and experience to help us out. So we're going to have Fred Thiel on our next meeting. It's going to be municipal power, and you can tell your friends that they can tune in. Thank you so much.
And you can register on the Limbo website, and the recording of today's meeting will also be up on the resources section there soon.
It
Thank
will
you.
also be a Zoom meeting, but I admit the one after that may not be. We'll see.
Okay.
Bye, everyone.
Have
Bye,
a good
everybody.
day.
Thank you.